This is Live Well Talk on Transcatheter Aortic Valve Replacement, or TAVR. I'm Dr. Dustin Arnold, Chief Medical Officer at Union Point Health, St. Luke's Hospital. St. Luke's introduced TAVR, catheter-based replacement of the aortic valve, to Cedar Rapids, performing the area's first procedure in 2016. Since then, the heart team has performed nearly 800 TAVRs. Here to talk about the procedure today is Dr. Richard Kettelkamp and Katie Maybanks, ARNP, from St. Luke's Structural Cardiac Team. Dr. Kettelkamp, Katie, welcome to the podcast.
Thanks for having us.
Thanks.
We've covered it before in previous podcasts, but just for the listeners, tell us what a TAVR is.
Sure. It's a catheter-based, so it's a non-surgical way to replace the aortic valve. So before 2016, the only way to do valve replacement, to replace the exit door valve to the heart, was to do open heart surgery. So this provides a approach that isn't as invasive. And it actually opened the door for a lot of people who couldn't have had it otherwise.
Right. That's the next question is, who has TAVRs? I mean, what type of patients do you see?
Katie and I started this whole program back in 2016. And when it started, it was really designed for people who were non-surgical candidates.
Right, severe emphysema, et cetera.
Exactly. So they were just, and it opened a door for people who just couldn't have TAVRs. Now it's anybody who needs an aortic valve replacement can have a TAVR because it's been FDA approved for all comers. But there's some caveats, and I suppose we'll touch on that as we go down the road. But most patients who get TAVR tend to be older. They're elderly. They're in their 80s, and this is just degeneration of the valve. So they tend to not be as good or as robust a surgical candidate.
What sort of symptoms would a patient have if they had aortic valve disease?
Shortness of breath, exertional symptoms is the primary finding. Occasionally people will have chest pain, pressure, heaviness in their chest with exertion. Some people will pass out with exertion, so they have what they call exertional related syncope. Some people will develop heart failure.
And what patients develop aortic stenosis or aortic valve disease?
It tends to be a disease of degeneration of the valve. So the valve wears out. It gets calcified, it gets thickened, and so it tends to be wear and tear. So as you get older, your valve wears out, so part wears out. Occasionally people are born with an anomaly where the valve is made up of 2 leaflets instead of 3 leaflets, and those valves tend to fail earlier. So instead of in our 70s and 80s, maybe those valves would fail sooner, like in their 50s and 60s.
Now, refresh my memory though. When it first started, you couldn't do the bicuspid valve, right? That's something that's developed, Katie, yep. Right?
Absolutely. So as the process has developed, so have the indications. And so since it's been so successful, we're able to offer it to, and the FDA has approved it to be offered to older patients with bicuspid aortic valve stenosis. So they have a choice, whereas before they didn't.
But younger patients that have bicuspid valve could also be a candidate now.
Correct. Yep. Generally speaking, we see patients over the age of 60, but we have seen some younger patients in their 50s that have other maybe medical illnesses that make going through an open heart surgery more daunting.
Well, speaking of the surgery, can you just ballpark complications from TAVR, complications from surgery, just to give a point of reflection on that spectrum? We
generally say there's a lot of workup for TAVR, so you have to do a lot of pre-testing to roadmap our procedure. So patients have to do invasive testing, look at their heart arteries, CT scans to measure the heart valve because we're not opening anything up. Whereas open heart surgery, generally you're just scheduled, you get it done and then have a longer recovery, where in turn you have workup for the TAVR and have multiple appointments, but afterwards you really have minimal recovery and minimal downtime, and that's much more accepted and appealing to our older patients. So yeah, minimal recovery versus the open heart surgery.
Okay.
Yeah.
You talked about the big workup ahead of time. Could you just give an overview of that multidisciplinary team that reviews these cases and just the role of people on there, et cetera? I think listeners would be interested to know that.
So we do pride ourselves on having a multidisciplinary team and using shared decision making. So each step of the way that the patients have In regards to the workup process, it's reviewed by multiple doctors, not just the doctor performing the procedure. And then we're making sure that we are headed in the right direction for the patient. It's the best option. So we do invasive testing like a heart catheterization in the heart lab, looking at their heart arteries. They meet with the surgeon, they meet with the structural proceduralist, and they have a CT scan to measure their artery pathways, so mapping out the procedure. And then they have other maybe extra testing if needed. They have dental clearance, things like that. So that can be, a lot of extra appointments, but knowing that the team is looking at those along the way, again, making sure that the procedure is the right one for them.
You mentioned dental clearance. Can you tell us why that's important? I think listeners would be curious.
Yeah. Well, dentists would probably say dental health correlates to good medical care too, and
they
medical
sleep
health.
at night and they don't work on weekends. So go on.
But severe bacteria decay in the mouth can unfortunately migrate down to artificial material in the heart. So generally speaking, for any implant that you get in the heart, we like you to have a good checkup, a good cleaning, just an examination by a professional dentist, making sure that they feel you're not at increased risk for infection for the valve. And honestly, for a lot of patients, that just sets them up for understanding that dental health also is good to continue on. So I think it's just good overall health to have that completed. But, it can be an ask for some patients, but we try to be thoughtful about that and help them understand why.
Ignore your teeth and they'll go away. That's what my grandma used to say. So after the surgery, do they have to be on a blood thinner?
We put them on antiplatelet.
Antiplatelets.
Right, unless they're on a blood thinner to begin with.
So super aspirin.
Right, basically.
But they don't have to go on Coumadin or one of the newer agents.
Nope. And again, unless they're on it already. So a person who's in atrial fibrillation, they'll stay on it and so forth.
And do they have to do rehab afterwards, like they do with open heart surgery?
Absolutely.
Always recommend it. It just sets someone up for, improving their symptoms faster. They have that extra monitoring from a professional, medical staff that can communicate to their primary cardiologist. And generally speaking, I find that patients get better faster if they put some, time and effort and commitment into their heart health.
Yeah.
Now we've moved cardiac rehab over to the medical plaza, the medical mall, right across from cardiology. Have patients like that being right next to the...
Oh, yeah, I think so. Yeah. I mean, some people miss the track.
Mm-hmm.
Everybody would go over and they'd walk. But what's nice is you can walk the PCI building. So it's
actually...
Which is very pretty.
Larger
very
than
pretty,
the track.
yeah.
Bigger.
And,
right.
That's probably a quarter mile at least.
Yeah. It is nice. It's nice to have everybody there.
Yeah.
Right.
Yeah, proximity makes a difference. It does. I know Dr. Whitey, the cardiac surgeon, is in your office now within the last year, that transition. And that's been a good move as well.
It has been more than I think we expected.
Like all hospitals, we're always remodeling and constructing. And I know we have a hybrid operating room that's being developed. The TAVRs will move to that from the vascular lab at that time, correct?
Right. You bet. I think that's slated for probably this summer.
Yeah, I believe so.
Something like that.
By the end of 2026, I know that for sure.
Right.
Still do them on Tuesdays, TAVR Tuesdays?
TAVR Tuesday.
Forever.
Yeah. There's occasions where we'll move it, like an urgent case we'll add on, but it's almost always TAVR Tuesday.
Maybe you could get like some sort of Taco Tuesday, TAVR Tuesday.
I think we need T-shirts is what we need.
Yeah, or free tacos.
Or bumper stickers.
At least that. In the preamble, I mentioned 800 cases. How's that been? I mean, success? You feel good about where you're at?
I think it's a remarkable achievement to hit that. That's a big kind of landmark, and to do that in that much time. And we've actually grown from maybe doing 20 cases our first year to now doing close to 120, and probably slated to do 140 this year. So that's a lot of patients that we've provided care to and improved their lives.
And you're drawing from around the service area, Eastern Iowa, not just Cedar Rapids.
Yeah, I mean, we have patients, I think the most patients have driven at least several hours, if not 4. We pride ourselves on our program and our outcome, and word of mouth spreads. And I mean, not that it's easy for them to get here, but we make it, hopefully worth their while, and they feel good about coming here for sure.
And, to Katie's credit, as well as Amy Mann, who's, kind of your right-hand woman, this is the only...
That's kind of a pun.
Yeah, I get that.
Amy Mann, who's the right-handed woman.
Yeah.
Oh, I like that.
Yeah.
This is the only accredited TAVR program in the state. And that means something, because that requires constant ongoing quality improvement, and, how can we make things better. So we're always looking at our data and our...
And I also say, when you have accredited programs, we have several.
Correct.
That also is a buy-in from the medical community and the leadership of the hospital to see the value in that.
Yeah.
True. Right.
Whether it's total joints, whether it's stroke certification, chest pain certification, there is an expense to that.
Sure.
But we see the value and the return on that.
You bet.
Yeah, absolutely.
And it does. It reflects in the program.
And all the staff from everyone that participates in it sees the value in it.
I think all disciplines have increased specialization, but it's been interesting to watch the transition of the old cardiology PC to where it is today as far as EP, electrophysiology. We've done several podcasts there. Dr. Rasmus is on as a new physician. Valve clinic, valve disease, heart failure clinic, interventional structural disease. That really has been a dramatic evolution, I think.
Oh, there has. Yeah.
And I really, Dr. Kettelkamp, you and I came to town just about same time. 2005, correct?
2006.
6, you're just a little after me. But I think cardiology PC, which ended up being Unipoint Clinic Cardiology, was kind of on the horizon, saw the vision to where things were going, and made that move sooner rather than later, in my opinion.
No, I think you're right. I think there's been a real investment in subspecializing.
Yeah.
And saw that was coming. One example is we were one of the first adopters for radial approach for coronary intervention.
Yeah.
We saw the benefit in that back when 2% of the programs in the country were
and just for the listeners, what Dr. Kettelkamp, instead of going through your leg, they go through your wrist to do a left heart cath.
Right.
And to think that doctors around the state resisted that, when you look back on it,
right, that
just blows my mind.
Sure.
That people are like, oh, no, we're not going to change. That is...
Well, it's the old dog, new tricks.
Yeah. I don't know. Wagdy did my heart cath through my wrist, and he's an old dog.
Yeah.
That's true.
So that old dog can learn
He
something.
knew better.
He knew better. No. I don't know if he listens to the podcast. I'd be surprised.
We'll find out.
We will.
We're going to find out.
Yeah, if my phone rings, and I'll know he was listening. Dr. Kettelkamp, Katie, thanks again for joining me today and sharing the information regarding TAVR, our accredited program that we're quite proud of. Once again, this was Dr. Richard Kettelkamp and Katie Maybanks from St. Luke's Structural Cardiac Team. To learn more about heart care services at St. Luke's Cedar Rapids Hospital, visit unipoint.org/CR-heart. Thank you for listening to Live Well Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.